Hi, my name is Dr. Jessica Kent. I'm an emergency physician as well as a clinical pharmacology and toxicology fellow in Toronto. In this video, I'll be discussing the use of lab testing in the clinical setting when managing patients with an alcohol use disorder. Of note, the American Society of Addiction Medicine underscores that drug testing is one of the many tools which can be used to provide comprehensive addiction treatment to patients. In combination with a patient's self-reported substance use history, drug testing can aid in diagnosis, guide treatment planning, and monitor patient progress. While traditional urine drug screens are commonly used to manage a number of substance use disorders, they do not typically test for ethanol and therefore can't universally be used for patients with an alcohol use disorder. Instead, providers must request specific alcohol-related biomarker testing. Although several of these alcohol-related biomarkers are available, each one has its own set of strengths and limitations. The primary alcohol-related biomarkers with the best operating characteristics used in clinical setting include the following. 1. Blood ethanol testing. 2. Urine ethyl glucuronide and ethyl sulfite testing. And 3. Blood phosphatidyl ethanol testing. We will focus on these three tests, although it's important to note that other tests such as aspartate aminotransferase, or AST, alanine aminotransferase, or ALT, carbohydrate deficient transferrin, or CDT, gamma-glutamyl transferase, or GGT, as well as breath alcohol via breathalyzer and hair testing in forensic settings are also other tests that can be used as alcohol-related biomarkers. Before ordering such alcohol-related biomarkers, clinicians should have a thorough understanding of each test's specific characteristics, including their windows of detection, to avoid misinterpretation. By learning the nuances of alcohol-related biomarker testing, clinicians can ensure their appropriate and effective use in the clinical setting. All right, so let's dive in. The first test, blood ethanol testing, a test that most clinicians will already be familiar with. What it tests for specifically is ethanol in a patient's blood sample, which is done either via enzymatic assays or gas chromatography. The window of detection for this test is approximately 6 to 12 hours after ingestion. The strengths of blood ethanol testing are that it has a pretty quick turnaround time in relation to some of the other tests we'll talk about. From a limitation perspective, however, the body metabolizes ethanol quickly, so it can only really be used to detect the presence of ethanol within a few hours of use. Additionally, while these tests detect ethanol, false positives can occur if patients are using other ethanol-containing products, such as mouthwash. In summary, blood ethanol testing can be used to detect acute alcohol consumption, but is not really useful for predicting withdrawal or to be used when monitoring abstinence. The second test is urine ethyl glucuronide or urine ethyl sulfite testing. Now, what this test is for is a urine test to detect the presence of ethyl glucuronide and ethyl sulfate, respectively. By the way, these are both metabolites of ethanol. The window of detection for these metabolites are usually within about 1 to 3 days after the last ingestion, but up to 5 days is possible. Strengths of this type of test is that urine ethyl glucuronide and sulfite testing have quick turnaround times as well, and they're relatively specific for the presence of ethanol. As an added benefit, urine ethyl glucuronide and ethyl sulfite are metabolites of ethanol. Therefore, they offer an extended window of detection when compared to blood and ethanol testing. Now, there are limitations. Of course, similar to blood ethanol, false positives can occur due to improper storage and incidental exposures to ethanol-containing products and some medications. Furthermore, the prolonged detection period makes repeat small exposures to things like mouthwash especially risky for triggering a positive test, especially if you have a lab which uses a low threshold. In summary, ethyl glucuronide and sulfate testing can be used over blood ethanol testing for both recent alcohol use as well as short-term monitoring. Due to the sensitivity of these tests, false positives are not uncommon. The final or third test we'll discuss is blood phosphatidyl ethanol testing. Now, what this specifically tests for is a blood test that measures the abnormal phospholipid phosphatidyl ethanol. Phosphatidyl ethanol is formed in cell membranes, typically of red blood cells, only in the presence of ethanol. Typically, the body uses water to form phosphatidic acid, but in the presence of ethanol, the body will actually form this phosphatidyl ethanol instead. Similar to hemoglobin A1C, blood phosphatidyl ethanol measures cumulative alcohol exposure over time. The window of detection for this test is much longer than the other ones we've discussed. up to 3 weeks after the last alcohol intake. The strengths of blood phosphatidyl ethanol testing are that it's only formed in the presence of ethanol. If no ethanol is consumed, no blood phosphatidyl ethanol is formed. Furthermore, this test works well for adherence, for alcohol abstinence, or reduction of alcohol use. Unlike the aforementioned tests, blood phosphatidyl ethanol can be used to roughly qualify an exposure, with higher levels correlating to regular or heavy drinking, although the distinction can't be made between regular use and binge pattern use, which requires, of course, discussion with the patient. From a limitations perspective, it's important to note that this will not form as quickly as urine ethyl glucuronide or sulfate, so it's less suitable for acute use. Also, it can't distinguish pattern of alcohol use, nor can it be used as a definitive quantitative test. Also, it may not be readily available as it requires a specialized lab for testing and understandably can also be more expensive than the other tests we've discussed. Lastly, rare false positives can occur in the context of blood transfusions. In summary, blood phosphatidyl ethanol testing can be used for the long-term monitoring of chronic alcohol use. In conclusion, urine and blood tests for alcohol biomarkers such as ethanol, urine ethyl glucuronide and sulfate, as well as blood phosphatidyl ethanol, can be valuable tools when managing patients with alcohol use disorder. However, it's crucial to remember that no test is infallible. Individual metabolism, hydration status, and incidental exposures, among other things, can all influence test results. By familiarizing yourself with each of the test's strengths and limitations, you can order and interpret results more accurately, ultimately providing clearer guidance to your patients. If doubts arise when interpreting test results, please consult your hospital clinical biochemists, who can offer specialized insight and clarify any discrepancies. Above all, recognize that these tests are, of course, just tools, and it's important to remember that they do not replace meaningful conversations with your patients about their alcohol use and treatment-related goals. Thank you for watching.